first CommonBondz Zoe Rogers Speaker Series event of the year. I hope everybody had a wonderful and safe holiday season, and Happy New Year, since we haven't seen many of you for a while. So I'm Mike DiCandido. I'm the co-founder and board chair of CommonBondz. Just a few housekeeping pieces, and then I'll turn it over to, I'll introduce Joy and Jason and turn it over to Jason. So we ask you just to mute your computers if you could, and you certainly can keep your speaker on, your video on if you'd like, or if you want to turn your video off, that's fine. Up in the upper right-hand corner, you'll see a box with 3 lines, and that's the chat feature. So many of you have joined us before, but if you haven't, that's where you can ask your questions. So Jason and Joy will have a dialogue, but if you have any questions that come up, please put them in there, and Jason will see them, and we'll get to them. Our commitment is always to try to answer everybody's question if we can. And also the chat feature has been nice for folks to share information, resources, those types of things. So as a community, if there's things that you want to add to the conversation or reinforce, feel free to use that feature. And then you can go up to the upper right-hand corner and go onto speaker view if you only want to see the speaker. The gallery view will show you everybody that's on the call. So without further ado, it's great for us to have a wonderful speaker for us tonight. As you all know, we're focused on racism in healthcare this month. So I am pleased to announce and introduce Dr. Joy Cooper. Dr. Cooper is a Philadelphia native and obstetrician gynecologist at Highland Hospital in Oakland, California. She completed her residency at the Hospital of the University of Pennsylvania. She earned her MD from Howard University, completed a master's in sexually transmitted infections and HIV at University College of London, the London School of Hygiene and Tropical Medicine, and she earned an AB in African and African American Studies at Harvard College. And she put this in her bio, when she's not on call catching babies, I love that, or traveling the globe, she's fulfilling a mission to impact women of the American diaspora diaspora organization through her organization, Daughters of the Diaspora Incorporated, and her telemedicine startup called Culture Care. So Dr. Cooper, wonderful for you to join us. So thank you. I also wanted to introduce Jason. Many of you who've been on our calls before know Jason. He's a wonderfully talented young man who we're privileged offers his great facilitation skills. He's a native of, he'll be our facilitator tonight. He's a native of Haverford, Pennsylvania, a suburb outside of Philadelphia, and he's currently the sports director at Crump 4 News in San Francisco, California. He attended Malvern Prep High School, a private Catholic school in Malvern, PA. He went to Syracuse University and graduated with a bachelor with a broadcast and digital journalism degree, and has pursued his dream of being a television sports anchor, and he does a wonderful job for those of you who follow him, and many of us religiously do on social media. So he is also on our board. As a number of folks on this call are, we really appreciate all his commitment to our board and to our mission and cause. So Jason and Dr. Cooper, welcome. And Jason, I'm going to turn it over to you.
Cool. Thank you, Mike. Appreciate the warm welcome, and thank you, Joy, for hopping on with us and having this dialogue. Mike already mentioned it, but if you guys have any questions or have an opinion or anything that you want to contribute to the conversation, just throw it in that chat feature, and we will get to it for sure. I want to thank you guys for joining the call, obviously, because I know everybody has their own busy, hectic lives, and so the fact that you take some time out of that to hop on this call is very, I really do appreciate it, and I think I can speak for everyone at CommonBondz that we all appreciate it, because without the input and the participation from you guys, you know, we wouldn't be able to do all this stuff. So it does not go unappreciated. But let's just start with Joy. We'll get right to the conversation. Joy, if you could tell me a bit about your background and tell the audience a bit about your background in terms of where you grew up, how you grew up, just your environment, and I guess what sort of molded you and led you to pursuing the career that you currently have.
Thanks again for your warm welcomes. So I am a Philly native. I'm from the Mount Airy section or Northwest Philadelphia. And I guess what got me to here is a couple of different things. I would say number one, like, I grew up with both my parents in the household, and, a lot of my family does either music or medicine. So I have a couple aunts who are nurses, and then everybody else plays the piano, organ, all these other things, and lots of teachers. But I will say, when I was in high school, I think those are pretty much my most formative years. I was blessed enough to go to Girls High, or Philadelphia High School for Girls, which is a unique experience because it's a public all-girls high school, and one of the few, I think it's the oldest remaining. There are some more charter schools that have come along since I've been in high school, but it's been around since 1848. And it was a very unique education system. And seeing teenage pregnancy when I was in high school, and seeing how different girls were kind of like stigmatized, and how there weren't a lot of places to run to for information. And I guess I kind of had that like nerdy spirit for OBGYN stuff when I was in high school, like in health education class, like I was on it. I remember I got recruited by my volleyball coach to come to one of his health classes because I knew all the contraceptive methods, and he's like, "You guys have a sophomore outshining the seniors." And so I think I've always been, wanting to do this. And then my mother's godmother actually is an OBGYN, and she actually went to Howard University for medical school back in the 60s. And I think having her as somewhat of a normal person in my growing up, and just knowing that, what's possible, I think that also made it so that it's oh, of course I'll be an OBGYN. Of course I'll do these different things. And honestly, I have to say, this mission that I've been on, I feel like there's, sometimes I do it kicking and screaming, because I also do creative things, because my family also is very creative. But I will say, I definitely feel this is the mission I'm meant to be on, and the things that I've done have definitely brought me here.
Nice. Well, shout out to Girls High. My mom graduated from that high school as well. So, you said you had family members who are also in healthcare. So you were exposed to that career path, at a young age. Once you graduated high school and you seriously started to pursue it, and whether through coursework, internships, residencies, whatever the case might be. Excuse my ignorance. I don't know all the terms. I'm not entrenched in the medical field. But once you started really getting serious about it, obviously it's a space that's typically dominated by white people, or at least I could say there's not as many people of color and blacks in that career field as probably you would hope. What was the experience like as a young black woman navigating through that space?
So I will say, it's definitely I'm a super minority in the field. So 3 to 5% of all physicians in the U.S. are of African descent. So definitely a part of the minority. I will say one of the better things about where I am now as an OBGYN is that actually 10% of all OBGYNs are Black females. So there are a little bit more of us. I would say, at least when you go to meetings and stuff, you're not usually the only one in the room. But I think what that kind of says, what these numbers mean is that if you think about the attrition, if you think about how many steps it took to get to where I am and how many people didn't make it for where I got to. And so I will say, I think the thing that was the most annoying was how many times I was told no. And I think one of the first times in terms of trying to pivot towards being a physician, because I was an African American studies major in college. So, I did fine in those classes, but the science classes were really tough coming from a public school in Philadelphia. But I will say that Harvard's the counseling, they were I remember being told specifically, you're not going to get into medical school. And it wasn't oh, okay, what are you going to help me? And a lot of my friends who are African-American got that same feedback. So unless you were top, a lot of people were told no. And that was kind of disheartening because it's like you're telling a soon-to-be Harvard grad that you're not going to get into medical school, and it's like, isn't it your job to make sure I get there? Like, what are the strategies? What else can I do instead of you just saying no? But I think when I didn't go to medical school initially after college, it was great because it led to an opportunity for me to see another healthcare system and education system. So when I studied in London, it was interesting how me being Black, me being all these things that are so major in America did not matter once I went to London. The education system, like I honestly, like the first day I started school there, I was told by the program director, like, you got in because we couldn't say no based on your letters of recommendation, but this is going to be hard because typically in the UK, if you do a master's program or graduate program, you like have done some work. And I was coming straight out of college, so I had no experience. But they still gave me the opportunity. I still did well. I learned so much. I found my program on Google and didn't know I was going to some these are some like the greatest universities in the world. But I think it was interesting to see what it was like when you don't have so much of like the bias. Even in my job, I never felt, so I also worked at a clinic there. I got to see their healthcare system. I worked at an STD clinic, and seeing how the healthcare system works there, as well as, and that's not to say it's free from bias, but it's definitely different from the bias I've experienced here in America in terms of working in a place and, people feeling you're a certain way because of your background, or expecting certain things from you. So I think honestly, to get where I am now, I've been told no a lot of different places, but I think being in the UK gave me an opportunity to be encouraged and see that who you are as an individual is what really matters, your work ethic, what you bring to work, your drive. Those are the things that matter, because I think sometimes in the American, system, meritocracy is not really a thing. It's really like, who it's your networkocracy. Like it's basically who that can get you where you're going. And if you're not in those circles, you're kind of like eliminated. So I've seen so many people, even when I was at Howard, people who had, who aunts and uncles were professors and who weren't necessarily African-American or of African descent, they got admitted to medical school with worse, MCAT scores than I did because they knew somebody. So it's all around in America. That's, I think what really holds us back and gets us to the attrition, because it's a whole nother discussion in terms of how do you take these exams that are expected of you to become a physician. Like that's a whole nother discussion in terms of with my background, with my way of thinking, all those different things. Like how do I score high enough to make sure I get to medical school, that I pass my boards, that I get to the residency choice of my choice, basically.
Nice. And it's interesting to hear you say in Europe, you kind of believe that the system they have in place is a little better than the American system. And I think in America, of course, this is a great place to live, obviously, but we have this notion that we're the best at everything, and it kind of creates a thinking that we can't get better. So we're like stuck in neutral, and we have this ignorance when there are other nations around the world that are doing really good things. So it's just interesting to hear that perspective. Joy, I think I kind of jumped the gun because as you were telling us about your experiences, you mentioned like 3 or 4 different schools, all so impressive. Can you just tell us, go in order, your line of education and which schools you attended, just so we know as we're going forward where you were and how you got there?
So he read my bio, so I don't want to bore people, but
no, hey, speak it up. It's impressive. You worked your butt off to get through these. Let us know where you went. Don't be humble.
So I went to Harvard College after high school in Philadelphia, and that honestly was just a dream that I had from 16. I was like, I think somebody who was a valedictorian went to Yale, so I was like, oh, I'm gonna go to Harvard. I'm gonna be like, the Black girl who goes to Harvard from Girls High. So check that box. And then afterwards, my college roommate, my best friend, she actually was going to London School of Economics. And so she was like, when I was like done college, she was like, totally need to just come to London and use, the education system there. And I was like, oh, let me see. They had different days that you could actually apply. Like you could apply towards the summer. So I actually ended up going to the London School of Hygiene and Tropical Medicine, as well as University College London, which were like a joint program in STIs and HIV. That was also just because I knew I wanted to be an OBGYN, and knowing those things will help me in the future. And then finally, I went to Howard University College of Medicine for medical school once I came back to the US.
Okay, great. Now, as you know, as you're going through all these schools, and obviously, especially when you're here in the States, outside of Howard, of course, you know, there weren't many people who looked like you, I'm assuming. And what challenges did that pose, especially in a field that, like you said, is so competitive? And then on top of that, here, it's not really merit based all the time. You know, it's not what you know, it's who you know. What challenges did that pose just for being, you know, a Black girl from Philly and probably a little bit out of your element, but qualified at the same time, but still, you know, just in a space that's kind of foreign?
I would say community, like, you know, despite being a minority, I think community helped me, and it was difficult. I think honestly, so I was African American Studies major at Harvard, which I think was a very nurturing place. Like the classes were small in African American Studies, like you would just read a book per night. I just loved it. I was like, you know, focused on literature, African American literature, and I like loved it. When it came to the science part, that was when it was like, whoo, this is hard. And I honestly just had to use a lot of my resources in terms of teaching assistants, in terms of like, I had like this one, you know, I went to school in Philadelphia where we didn't have, you know, a lot of people I went to school with went to like Exeter and all these places, Andover, that had like, you know, state-of-the-art labs. And I had never had a lab. Like I remember the only lab I had at Girls High was like a demonstration of how do you make coal, and you're like, eventually this will turn into a diamond. Boom. And I was like, oh, okay. But, you know, I get to Harvard and you have to use a pipette, all these different things. And I honestly just like, you know, use my resources in terms of talking to, you know, people who did have the experience. Like, okay, you're going to be my lab partner. You're going to help me get to know what I need to know so that I can pass this class. But I will say, like, you know, just building my own community was, you know, pretty great. I always say, and I know this is offensive to some, but there was a Howard at Harvard, despite only, you know, there's like, what, I guess there's like 5,000 or 6,000 of us in the whole university, but there was 7%, you know, of those students were Black. And so of those, we created our own community. Like I pledged a Black sorority when I was at Harvard. It was not AKA. I'm not sorority sisters with Kamala Harris. I'm a Delta Sigma Theta member. But, you know, I had those opportunities to help me build community with like line sisters who went to MIT, who went to Tufts, who went to Wellesley. So I was able to build the infrastructure to make sure that I was surviving at Harvard and that I was also thriving. Beyond that, you know, I would say, you know, I think the hard part was after Howard. I think Howard was great because as a physician, as a budding physician, to be a place where a Black physician is normal was an amazing, empowering thing to see, you know, like pretty much it didn't matter what specialty, it didn't matter, you know, people weren't picking on me based on, you know, like it was literally like, again, back on the merit thing, like you do good, you do great, we're here for it. But I think once I went back into residency, it was hard because, you know, when you're starting as an intern, everyone knows nothing. That's the whole point of an intern, is that you're coming in knowing very basic stuff, and that over that first year, you're supposed to like really just have a really like steep learning curve and get to know everything so that you're like, can do most things by the end of the first year that are within your level. And I kind of felt like intern year, and I feel like with all like, you know, Black interns that I've met, is that there's not a lot of grace given in that first year. You're kind of like, any mistake you make, it's like a big thing. It's like, oh my gosh, I can't believe you did that. And it's like, well, where else am I supposed to make this mistake? Like, this is how, as long as I'm not killing someone. I felt like my intern year goal was like, do not kill somebody. That was your main goal. You know, make sure people have pain medicine, do not kill anybody, and ask your senior. Like, that's just what it is. And I felt like sometimes it was hard to get that grace. And I think that was really the hard part with training because I feel like some of those biases came in.
Okay. Now, so you've been entrenched in that in this career field for a while now. You know, my main question for you, and we'll get to a whole other things is, and I see the stats all the time, but I don't know how to you know break down the stats and actually understand them. But why does it seem like by the numbers that African Americans have significantly more health issues than pretty much any other race or ethnicity?
So that's a weighted question in terms of, because I think that the hard part was, and this is what I learned actually when I was in London, because when I was in the UK, and I think these are things we're talking about now are so in the articles and stuff now, but when I was in the UK, I was baffled because, I went to a school that was centered around like global health essentially. But pretty much, the US is, a developed nation. And so honestly, when it came to pretty much any STD that I was studying at the time, it was, the major, populations we had were some African country and then US Black. And I was like, what is this thing that like US Black all of a sudden is like this developed nation within the US? And I think the problem is in terms of how our healthcare system is set up. We do not have socialized medicine like the rest of the developed world. We're the only nation that does not have socialized medicine where pretty much everybody has access just for being here. And I think a lot of that is because of racism, because we don't feel like ever since, slavery ended, it was like, how do we make sure that African Americans are not a burden? And so a lot of policies were always put into place so such that we don't give out, just like, we talk about welfare queens, we think of like a Black woman from the 80s with big earrings and, big hair. But honestly, the majority of people in America who are on welfare are white people. So it's just kind of like, it kind of is this thing where it's like, how do we keep resources from certain communities? But I think this question is pretty weighted too, just because I think most of the healthcare issues that we have in the US, which are obesity, high blood pressure, cardiovascular diseases, what kills most people in the US. When you look at the Black population, most African Americans live in a food desert. So how can you expect people to take care of diabetes, not have high blood pressure, not be obese when they don't have supermarkets in their neighborhoods, but they have Popeyes, they have all types of chicken joints and all types of fast food, Chinese restaurants, that fry wings, all these different things that will make you unhealthy and make you unwell. And you also don't have hospitals in your neighborhood. You don't have doctor's offices in your neighborhood. And so essentially we're setting, I think, things that have happened over, probably like the last 50, 60 years have just, worsened, because even if you do, let's say you get a Whole Foods or a Trader Joe's in your neighborhood, that means you're about to be pushed out of your neighborhood. Doesn't mean that it's actually for you. So I think in general, it's like, how can you be well if the system wasn't created to make sure you were well? And if you really look at the history, even beyond, Reconstruction, and you look at slavery, African Americans actually were utilized for, actual, so, if you look at gynecology, the father of gynecology, J. Marion Sims, he actually performs surgery on female slaves with the consent of their masters without anesthesia. And so he would, repeatedly do procedures until he felt like he got it right and got to what he wanted. And so you fast forward then to, the Tuskegee experiment, where men who had syphilis in the South were not offered therapy because they wanted to see actually how does syphilis change over the years. And so a lot of our understanding about syphilis is really from not giving, penicillin to when we had a treatment. And then you fast forward to like LA, where they were sterilizing, women and no mas babies, where they were sterilizing Mexican women to make sure they didn't have children. So there's a lot of historical reasons why people are unwell, because, people of color have, classically been the brunt of how do we, manipulate healthcare instead of how do we actually serve people in terms of healthcare. So I think it's just a weighted issue in terms of all of the different reasons. And this is why I'm an African American Studies major, because, I was at least, just because it's not like it's just, science. I wish I could say it was science, but it's more and more the social things that actually shape our healthcare system.
Yeah, wow. Great answer there. And I know my question was very complex, and it wasn't just this is the reason why. So have you, you just went through some of the historical context that has gotten us to this place and listed a whole bunch of examples. Have you witnessed this firsthand kind of while you have been, practicing medicine, where you've seen this and either you go to a supervisor or you just say to yourself, like, this is not right. This is not how we should be doing things?
You definitely see biases. I think that's like the hardest part. I think it's, I have this I have my own I think the thing I have to work on in therapy is like where you feel like I have to be there. And I think it's honestly, I wish I could say that I gave it to myself, but there have been situations where I've had patients that I've just taken special care of because, as Jesus would say, the least of these, like that's who, for me, like I've always wanted to take care of. And sometimes the least of these, the people who aren't VIP, the people who don't have the best insurance, the people who aren't the cleanest, and don't have the best jobs are the people that people usually neglect. And I remember there was a situation where one of my patients, I couldn't be there for their delivery because of work duty hours when you're in residency or, whatever. And there was like this bad outcome with the patient. And I came in the next morning, everyone's like, see, if you would have been here, it wouldn't have happened. And I'm like, it was not an outcome that like was not avoidable. Like, it's just like, why do I have to physically be here to make sure that people get the care that they deserve? And I think the problem is that, you have to have a spirit of treating everyone like they're a VIP in order to make sure that everyone gets equitable care. And I think that in the healthcare system, because, the way that America just is as a system, we give, better care to certain people. And I don't know, I've seen biases all the time. Like I've seen we over test Black women for, tox screens, looking for drugs and things like that. Because we assume, oh, okay, you're a Black woman, you must be on some type of drugs. And I've just seen some certain things like that. That thing, like, I think always like kind of gets me because it doesn't matter who you are. And that's why I feel like even for me as a, even if as a Black physician, like I shouldn't have to have my badge on to say like, oh, now you should care about me. I should just be able to walk into any place and say, take care of me. I'm a human being. But unfortunately, that's not the system. And you are judged. And I always tell people like, your Blackness precedes you. And that's like the problem in healthcare is that before I can open my mouth and say what my symptoms are, people are already putting you in a box. And so it's hard to be in a box in the healthcare system when you're in pain, when you're like, suffering from some, malady, if you're bleeding, whatever it may be, because how do I communicate for you to help me and understand and want to help me if you already are so wrapped up in, oh, you don't really matter in the grand scheme of things because you're already your own, and the implicit bias that we all are raised with that, Black people don't matter. And I think that's why for me, Black Lives Matter in terms of like the police and stuff is great and all, but I think it also really rings true for people in the healthcare system that we have to have that reminder as well.
Right. Now, all of the, horrific examples that you gave, where it was, they wouldn't treat black men who had syphilis because they wanted to see how their body reacted, and then they would practice on, slaves, practice certain procedures. Examples like that. Do you think that's the reason why Black people are so hesitant to get things like the COVID-19 vaccine, just because of the history of how Black people have been treated in healthcare and by, people who are supposed to heal us?
I definitely think that's a part of it, because the thing is, we're so used to not being offered something. So if something's being like, offered to you all of a sudden, it's like, I think that's kind of surprising. It's like, oh, wait, you want to give me the vaccine? But I think it's kind of a catch-22 because the reasons why we're dying at greater, rates are also the same. It's also linked into us being eliminated from the healthcare system and not having great care, not having hypertension under control, not having diabetes, and having like crazy high obesity rates. Those are also what make us more susceptible to dying. And so it's kind of a catch-22 because, it puts us at high risk for, dying from COVID, but it also, if we don't prevent it, then what do we do? And I think that history is it's a sordid history, and it's hard for me, even as a Black physician, to advocate for the vaccine because, people look at me like, oh, you like people would rather drink, all types of teas and lemons and all types of things than to actually take a vaccine because, what are you injecting me with? Are you going to like, even as there were some rumors saying that it will sterilize you and you can't get pregnant if you get the vaccine and all these other things, which are actually, false truths. And I think the problem is too, is like, in this day and age of information, you can make a webpage about anything. How do you trust the healthcare system if most of the healthcare system has never looked like you, and who's delivering the message? And so, if you have Dr. Fauci saying, yes, you should get vaccinated, but he represents the government and the government has always been a part of, your annihilation, then how do you say like, oh yeah, sure. So I think it's just, it's a really tough time. I think especially coming out of the last administration, because even if you look at, Native Americans who similarly probably have the same issues in terms of getting vaccinated, when the Navajo Nation was having their worst bouts of COVID, the U.S. government did nothing. Doctors Without Borders for the first time had to occupy U.S. soil to take care of the people that we refused to, that were our citizens, that, were the Native Americans that were first on this soil. So it's just complicated because the thing is, it's literally like a game of who do you trust? And meanwhile, COVID is still running rampant through our communities. And that's just because infectious diseases work based on your network. So 2 things about people of color is that A, they're more likely to be on the front lines in terms of working for transportation companies, working at these restaurants that everybody still wants to sit in without their mask on, working at all these different places that put them literally on the front line to make sure they feed their family. We're also not giving people money to stay at home. And so you take that plus, once you go back to home to your communities, I know especially where I work in California, we had patients who the COVID rates are so bad in their community because there's 15 people living in their home. So if one person gets that, everyone in the house is going to get it. And so that rate then is much higher. Because people just, don't have access to great housing. So, when you really look at, why we are here, it's super related to social issues. And it's hard for the government in a silo to fix it because the government is really complicit in why this is a problem. So, I don't judge people for not wanting the vaccine. I am just really trying to really educate people on the science of it and know that the science of it is sound. And that's a whole other problem. I think we just don't have good enough education in the US to really vouch for vaccines because we spent so many years, saying that vaccines are bad, it's linked to autism, et cetera, et cetera. So, people inject themselves with heroin, but not with the vaccine. So it's hard to battle those types of arguments.
Yeah, and being in your field is probably exhausting trying to constantly assure people, I'm sure. Now this might be a tough question to answer, especially because some of these issues, they're so complex and you can't just, snap your finger and fix them. And there's not really for the common person, a tangible action that you can make to make things better. But, I try, and we spoke about this in our pre-conversation, Joy, I try to give our audience, people who are sitting in on this, some things they can take with them that, help solve these issues. Now, I feel like most of these issues are going to have to start at the federal and the government level. But just for your average Joe, especially our white allies, is there anything they can do in their everyday life to kind of help these issues that Black people face in the healthcare system?
I would definitely say that allyship, couple things. So one thing, it's a very cliche thing. People say oh, I'm not racist because I have a Black friend. Well, fine. If you have a Black friend, make sure you text your Black friend and make sure they have their mammogram this year or their cervical cancer screening, their colonoscopy, all those different things that Black people are more likely to die of because we have higher death rates of literally every cancer because we don't get screened as much. So really one part of being an ally, just in terms of being a friend, and I do this for every talk I do, is text your friend to make sure that they're up to date with all of their screening because Black people classically screen late, and then we classically have higher stage cancers and classically die more often. So that's one thing you can do that everyone on here can do because everyone has a Black friend, right? So the others I would say is in terms of allyship, I think the hardest part for me as a Black physician, and the reason why I know there are biases with patients, beyond what I see and beyond, what I actually encounter at work is just, or encounter with patients, I would say is how I'm treated by my coworkers. And so when I see those same biases creep into how workplace things happen in terms of who's doing all the work, who's doing all the shifts, who is, taking all the bad shifts, and who gets more time off or who gets special dispensation, I think that's where allyship should come in. We have to make sure we're equitable at our jobs. I think that is the number one thing. If we can embody what it's like to be a great coworker, then those things emanate and, radiate out into the public. And I think that's my biggest wish for healthcare is that if we would be better to other to our coworkers, even just in, the hospital, being better to, requesting, just making sure like, oh, are we all doing the same amount of work? Because I can't tell you how many times I've seen in different programs, residency programs that I've worked with, different hospital systems where people of color are doing the brunt of like the scut work or the work that nobody else wants to do. And so I think, the key thing is to also look at that at your own job. Like, do you have those practices at where you work? Because I feel like that's a part of being an ally. And I think that's a part of D&I that will never, ever come from a D&I officer, which is, typically a person who's just been selected to be, I think it's kind of hard to like, especially when we choose people of color to be the D&I person. How do you tell a person of color, like to say like, okay, police everybody on how they treat people of color? Same thing with like, just like a Me Too thing. How would you choose a woman as like, oh, okay, tell the guys not to act this way anymore? So, not to say that it's only men, but classically it is. But I think the key thing is to really try and be the change you want to see in the world. I think like the real change comes from how do we treat each other, and not just like as friends. I'm talking about within institutions, because, when we look at, when these applications come across our desk for jobs and things like that, how do we judge people? I think that was the most important responsibility I was given in residency. Was for the first time I was at the table to decide someone's career. So in residency, we have a match list where all the applicants who are medical students, who are fourth year medical students, they come, they interview, and then you have to sit at a table and decide what ranking order people are in terms of able to come to your program. And I think my seat at the table, having that after my first year, especially because I think after my first year, I was like going to be the only African-American resident there. I first appreciate that my program let me have a seat at the table, even though I was young, but they valued my voice because I actually was African-American. Most of our patients were African-American, and they knew I could make sure I could contribute to make sure that doctors came to where we worked that made the patients feel comfortable. And I think making sure that you people who are quote unquote the least of these are people who don't necessarily have that voice, that you make sure those people's voices get elevated, I think is important. And that's a part of like D&I that we all can do from our own, like all of our work. Like you do not need to have, all of these titles to actually like execute those things.
Right. Wow. That was a great answer, and definitely some things that people can take with them in everyday life. So now I'm going to get to the questions because we have quite a few over here. So I am going to start with, okay, so that's not really a question. Okay, now, you are awesome. Thank you for being here. I'm very leery.
Hello?
Hi.
Yes, I'm sorry. I just unmuted myself really quickly. My name is Heather Wimbush. I'm in by phone, and I was a former labor and delivery nurse. I'd love to get a question if
Hey, you will get the first one. Be my guest. Oh, the floor is yours, Heather.
Hi, Dr. Cooper.
Hi.
Great to meet you. I was a labor and delivery nurse for over 20 years, maybe 24 to be exact. And it was really refreshing kind of hearing your perspective on everything. And I don't want to take up everybody's time, but it was interesting for me to watch how sometimes I worked in New York, New Jersey, North Jersey, and New York City. So I was kind of in the trenches up there, and it was very interesting to watch how, the care was given to the full range of patients, and even some teenage African-American young ladies who came in and were having babies so young. But I took on a mother role when those kinds of things happened, because I knew I kind of had to be extra good that day and taking care of them and making sure, their deliveries were safe and kind of advocating for them. I'm doing more of an emergency room observational type nursing now. So I'm working with the whole spectrum of the ages. And I am kind of sometimes disappointed at what I see happen to the African-American patients. However, I'll end on this, because as I said, I don't want to take up everyone's time. There's a young lady who my kids grew up with her, and I want to shout her out because she's actually, at one point was trying out to be in the Olympics as a fencer. She's now in med school, however, and she had on her Instagram the other day, she said the one thing she's finding out, I think she might be in maybe her first part of her residency, that she said the one thing she's picking up on, she does not think African American patients hold their physicians accountable and ask as many questions as she sees of other races and or cultures. And I thought that's pretty key for her to have picked up on so early. But I do believe not enough questions are asked. And I don't really know why. I don't know if there's some sort of an intimidation sometimes. So I just wanted to bring that up. And I want to say down here in Georgia, I do see a lot more African-American OBGYN. So I know there's more and more of them coming into the field, and I'm really happy to see that.
Thank you, Heather. So it's Mwambi Presley just commented, said, because Black doctors dismiss us. And I think that's the hard part with communication is certain patients are rushed. If certain patients are rushed, aren't believed. And so if you told someone something that, you don't think they're going to believe you, like you wouldn't take extra time to like keep advocating for yourself. And oftentimes I see that patients who do advocate for themselves, they're labeled as annoying, as, I hear the biases because, sometimes your medical assistant will tell you them, or other doctors will say, oh, she's so this or she's so that. And basically those things precede you as a patient and you don't even know it. And so you kind of get shut down after a while. You get tired of advocating for yourself when people don't listen. And so really what I honestly teach a lot of people, especially because I train residents still and sometimes medical students, is to actually give more time sometimes, give extra time. So one thing that I acknowledge in terms of my own bias, I'm an English speaker, a native English speaker, but patients that I have who speak like English as a second language, I give them extra time. Because sometimes I know that I'll take the time to talk to them, and who knows how long they've been waiting for someone to just give them the floor to talk. I also make sure I have a good interpreter. One thing that I do is I tell a joke to make sure the interpreter can make sure the patient laughs, to make sure that we're actually communicating. So there are things that you can do when you're actually, especially when classically this patient population does not get good care. That's the onus is on us. It's hard as a patient to say to the system, you need to ask more questions. I definitely know, I take care of white patients as well. When I worked at another institution, they asked a lot of questions and they were persistent about getting what they want. But I think also you have to understand that there are some layers of like white supremacy that make, white people able to advocate for themselves because they think they deserve it. If the whole system has told you don't even deserve this, you should be lucky you're even getting this visit, it's really hard to advocate for yourself. Definitely part of what I do at a lot of discussions with African-American patients is tell them to come prepared with questions, challenge their doctors and such, but it's really hard to do that because sometimes you will get shut down, and I know that firsthand.
Well, all right, great question. So for now, this is kind of answered a little of this. She just said, "You are awesome. Thank you for being here. I'm very leery of doctor-patient care. I try to be an advocate in the room for my family members. What do you think? They act different when you are taking notes." Thoughts?
People to take notes anyway, because this is your care, this is your encounter, and no matter what insurance you have, someone's paying for you to be here. But I think it's also a good idea to bring an advocate with you, someone who can be, because if you have someone with you, they're also objective. So let's say, they can say like, oh, I've noticed they do this. And so when you can say that kind of becomes more objective. That's not from your perspective of, I feel this way. So it's someone who can say, I've seen her do this, and that's concerning. Those are ways that you can kind of like add to the evidence that this is actually a thing. So I definitely encourage people to bring someone else with them. Writing notes, I know my mom calls me Dr. Have a Heart, and I know I'm really like forgiving with these things, but at the same time too, this is your time. This is your health, this is your body. You get one life to live, you get one body, and you have to cherish it. And to me, I'm like, whatever it takes for you to be well, I think you just have to really be persistent and be, audacious about it. So I don't care what if your doctor's annoyed or not, they have to take their time. And you could be like, wait, doctor, wait, like you can do that. It's annoying, trust me, but that's my job.
Yeah, I feel that. All right. I am nope, I'm sorry. I think I skipped okay, right here. I'm sorry. We have a number of healthcare workers on the call who are white. What can they do to learn more about how to relate and treat patients who are African American, understanding the challenges they have with health due to systemic racism and perceptions?
So I think that's a good question. So the hard part is this, there's two, the hard part is, that they do these like, diversity inclusion type hospital, modules where you sit online and you like, go through a slide show. But honestly, I would say there are really, really great webinars and podcasts. Let me see if I can think of specific ones. Let me brainstorm and I'll tell you at the end before the end. But they're really like, if you look up, healthcare disparities, if you Google that in podcasts, like even if people don't have a whole podcast dedicated to it, there are definitely different episodes. And it's definitely pervasive. So no matter what your specialty is, please understand that it definitely happens there. I really appreciate that question just because I think even some of my coworkers, that's when I realized people don't, I work in Oakland, California with a very diverse patient population. It's basically mostly Latina and Black women that I work with and some Asian women. And honestly, some of the like healthcare disparities, like education, like my coworkers did not know. Like I told my coworkers, like if I was to have a baby, I have a higher rate of, of mortality or dying in the first year after childbirth than, a white woman who has only been to high school. So despite all my degrees do not protect me. Despite me being a different social economic class, despite my salary, all these student loans I have, none of those things protect me because my race precedes me. And so I think the key thing is to really just Google is a great resource when it comes to healthcare disparities. Honestly, there are some websites that do great work and they're not all like, YouTube, kind of like, I feel like sometimes YouTube can have like crazy videos that are like, not really founded in evidence, but there are really good articles that have great evidence and will lead you to a lot of articles. One article that I honestly cite in my specialty a lot is one called Black Lives Matter. And it was in the New England Journal of Medicine. It's on my website for my Daughters of the Diaspora organization website, DODIASPORA.org. But we have like a reading list, and there are like a couple of articles that talk about healthcare disparities and amongst women's health. But there's one that literally goes every like part of women's health, whether it's cancer, whether it's fertility, whether it's obstetrics, whether it's gynecology, all of those different things. There's different statistics that say that, why Black people do worse or, how they do worse in terms of statistics. So the education is out there and online, and I am glad to live in this era where a lot of the education is there. Like we have articles coming out, like the article that just came out last year about how Black children who are taken care of by a Black pediatrician are likely to survive in the first year, more likely than they are with a white physician. So there's evidence out there that wasn't there before because nobody was, funding it, but there's a lot of evidence out there now.
Nice, great question. Our next question is from Matt. He's one of our board members. Joy, thank you for sharing your experiences with us. Is there an open understanding and dialogue amongst the medical community that systemic racism is so prevalent within healthcare and how to correct these wrongs moving forward?
No, unfortunately there isn't. I think I realized how tone deaf the medical community was when George Floyd happened and everyone was taking a knee in their white coats. Because unlike, police have body cameras and are in the street and it's obvious that you killed someone. We kill people in the hospitals, and people get away with it. And so, and we don't give people pain medicine, people get away with it. So we're also culprits in it. And I think we don't really identify why. I would say definitely that the problem with medicine is that same kind of nepotism that, is in most fields is that, it's who you know. And so if we don't, there's no standard in terms of how do you determine someone's racist or not to become a physician or to become a nurse. And so we just let all comers, that's never a rubric in terms of like, is it okay for you to be, just like, is it okay for you to be transphobic or homophobic, all these different things. And so we allow people into the healthcare system as leaders, as people who are in charge, and they're in charge of people's lives, and that becomes a problem. That said, I think the best example I can give of why there's a problem is, after the George Floyd situation happened, a University of Minnesota medical student actually defaced the mural of George Floyd in Minneapolis. And they did not fire him from medical school. Like they did not, we still don't know what happened to him. Like he was on leave for medical school for a while, but someone like that should not be a physician, because if you have to take, if it's okay for someone to stand on someone's knee, for however many minutes and kill them, and you don't want to see a shrine to them, and you would deface it, that's a, to me, that's a racist act. And so it was not stamped out. It was not like, oh, this person should not be a physician. And that's a problem, because that's a bias that's not necessarily just implicit, that's an explicit bias that they obviously have. And so I don't think we do a good job, even within our own specialty, of policing these actions. Even at my own job, trying to, say, so-and-so says these different things about the patient. Should they be working here? Because there are plenty of places you can work. You can work at Beverly Hills if you want to have the whitest, richest patients. Like, there are opportunities for that. But do not come and work for Medicaid and Medi-Cal type patients if you're not going to give them your best. And so I don't think we've really done a good job of making sure that people, like, if you're going to be in this position of power, that you don't wield that power for negativity. And unfortunately, in the healthcare system, we protect each other. So unless you really get reported to the medical board, it's really hard to make sure that those things get rectified.
Great question, Matt. This is from Sarah. I'm a professor in a physical therapy program, and we do have students read and discuss articles about racism within the healthcare system, but I think we could do a lot more. I think healthcare programs in general fall somewhere between not enough education and racism in healthcare. I'm sorry, that was more of a comment, but
agreed. I would say, they make us take ethics classes in medical school, so I think they should definitely add healthcare disparities as well, in terms of that's a realistic thing.
Yeah, for sure. And I got to the end of the questions. I guess a comment that I'd like to make, and it's more of a comment, not a question for you, but you've enlightened me, Joy. You kept mentioning, well, should this person be working here? Should that person be working there? And I think on the forefront, when you see those questions, are usually police officers, because they're policing communities, and you see them do this and see them do that, and you think to yourself, there's no way someone with that temperament or attitude should be working in a job like that. And it never occurred to me that doctors, who are literally the lifeline of some people, if they have that same ideology or way of thinking, or they're just a flat out racist, they can kill somebody probably quicker than a police officer can. So that's really nothing. That's something I always say, I've been saying for a while, and sorry that I'm rambling, it should be as hard to become a police officer as it is to become a doctor, a brain surgeon, because I feel like that would weed out, a lot of just the simpleness that we see. But
I think the power comes from once you've made it, once you're in that system, you're protected. So just like the internal affairs, I've watched enough Law and Order SVU to know internal affairs is who gets, sent on these cops who are bad cops. But what really happens? Do they actually get fired? No. It's so hard, even if you kill someone, to get fired as a police officer. And it's the same way in medicine. I don't know if there's a podcast called Dr. Death that talks about I think he was a neurosurgeon in Texas who was literally killing people and was not, doing surgeries correctly. And it took forever for him to get caught, because even the nurses weren't reporting him. They were just everyone was acting like it wasn't a big deal that people were dying, and his death toll was higher than everybody else's. And so if you don't have the proper ways to police within the system, then we're always going to lose. And that's the problem, is that, once you're kind of protected, once you get your, that's how it is with, medicine. Once you become a physician, nobody can take that away from you. Once you become resident, once you become board certified, no one can take that away from you. The only way you can really kind of work it in healthcare is the licensing system. And so if we don't report, physicians, who, to the licensing boards, it's really bad to get your license revoked in a state. That kind of is a red flag. It makes it hard to get licensed in other states. It makes it hard to get a job. That kind of will kill your career. But that's still seen as a really, really high, ceiling to have that even done. But that's, we have to be better about policing people once they're in. It can't be just because I made it here, I get to be here for forever.
Right.
Excuse me. Can you talk about the notion that Black people don't feel pain as much as other races, so that's why they're denied different treatments and medication?
So that definitely comes from, I would say, implicit bias, and I think also the historical thing. So I think when it goes back to, performing surgeries on like slaves without anesthesia. I think that's kind of something that was like passed down as if like, you know, African Americans have less pain. The only people I know who like, you know, classically, you know, this is actually like science. So it's like, I think redheads, they need different anesthesia because they actually like their pain is a little bit different. But other than that, Black people have the same pain as everybody else. Everybody has like the same pain tolerance. And the problem is that that's just a bias thing. The problem is that when we treat pain in the hospital, it's subjective. So if they say, what's your smiley face, the 1 to 10, if you tell someone, you know, that you're at a 10 and you look like you're at a 2, people won't give you pain medicine. And I've seen this happen in the hospital. I had a patient who was this little old lady, and she's like, yeah, I'm at a 10 out of 10 pain, but she's not screaming, she's not thrashing. And I feel like it doesn't matter, especially when you're a Black patient. You can be like screaming like, I need pain medicine, and be a 10 out of 10. People still will ignore you and say you're doing too much. Or you can be like, you know, really like stoic and say, look, I'm at a 10 out of 10, and people will still say they won't give you pain. And it really, I mean, that's the part that's hard to fix, because how do you know, train? And this is why I say it comes in terms of biases, in terms of who do we lead into medicine, and how do we measure who a good, you know, nurse, doctor, assistant, medical assistant, how do we measure who's actually good at their job? And I think the problem is that we have to take everybody's input. It can't just be the people like raving like, oh my gosh, they did such a great job, but also like, why did someone think you didn't do a good job? And like, you know, unless you feel like you're going to over medicate someone, there should be no like withholding. And, you know, case in point, there was an excellent example of a physician who has sickle cell. He had to travel out of state to give a talk as a physician at a conference. And, you know, sicklers have to take a lot of pain medicine because their crises are very painful. And so one thing I know about sickle cell patients from training at Howard, from training as a physician, sickle cell patients, you ask them, what are your medications you take? Like, what helps you, you know, prevent having a crisis? How much medicine do you need? And he went to this hospital emergency room, said, I need these medications. That'll make me get out of crisis. It's probably because I flew on a plane. I'll be fine. And they refused to give him that much medication. He ended up going from a pain crisis to a sickle cell crisis and being hospitalized and missing his talk that he was supposed to give at the conference. Despite being a Black physician, despite being, you know, like having all these accolades, no one listened to him. And he can't break into the pharmacy and say, give me these medications. And so if we don't listen to patients, how do we, you know, like we're not doing great. We're not, you know, we're like the healthcare system is sick. And I think that's a takeaway, sadly. And I don't really know how to force someone to give you pain medicine, because I think, you know, I've seen it on both ends. I don't know how you're supposed to behave to say that you're in pain. We just have to be more empathetic. We have to be more sympathetic to other patients.
Wow. Well, this was very, very, very fulfilling. And, you know, I'm seeing all the comments, people seem to agree. So I just want to thank you. And I'll hand the floor over to Mike.
April.
I'm sorry.
I think there's one more question though about from Nefertiti.
Yeah, the dictionary one. Yeah, if we can address that one.
So there are some startups. I know there's a company. So her question is about if there are a directory of minority physicians. So there are some directories. I know that Hewed Incorporated is one, and Health and Her Hue is another one that helps connect patients to people of color if they want to see another Black doctor. I definitely, you know, am a big proponent for pushing, you know, I think one privilege that you have as a white person is that you get to see a white doctor typically who understands you. And I think that the thing I always try and tell people that I train is that Black patients actually speak a different language. You know, we speak the language that we speak around others, like our coworkers, and, you know, but when we get on the phone with our moms and our family, we sometimes code switch. And so imagine having to do that when you're, even though it's still English, it's a different vernacular. And so if you imagine if you're trying to tell a doctor how your pain is or how your symptoms are, and you say like, you know, oh, you know, it's hard to, you know, code switch and to try and make sure you're translating it properly. And so one benefit of having a Black physician is that you don't have to pretend. And I feel like a lot of my patients, when I walk into the room, they just exhale like, okay, great, you're my doctor, so I could just tell you everything without having to make sure I say it in a way that you respect me and you feel like I'm worth, you know, the care that you're giving. So I definitely encourage people to find people who speak the same language, who come from the same community, just because it helps. I know even for myself, like, you know, I definitely feel more at ease when I'm with a Black physician. Yeah. Thanks, Neff, for that question.
Sorry, Neff, I didn't mean to skip you. I did not even see it. I had scrolled too far past it. I apologize. Yeah, I think that is the final question. A lot of people saying thank you. We thank all of you guys for hopping on the call, like I said in the beginning. Now I'll let April finish us out.
Wow, thank you guys so much. This has been such an informative and great conversation. Joy, I think Portia's friend Davida said something like, Joy is smart. She's very she's very knowledgeable about a lot of things, and Joy has always been very very smart, very informative. So thank you so much, Joy, for volunteering your time and for helping us to understand racism in healthcare. It's definitely been eye-opening. It's one of those things that you know it's happening, but you just can't, you can't put a word or a term or phrase around it, but you know it's happening. I mean, you know that you're being treated differently, or I never knew about the pain thing, because I think one of the things, at least for me, Portia says that I can stand a lot of pain, and maybe I can. I don't know. I guess we just don't have enough time to worry about, you know, oh, I got a headache or this or that. But definitely, you know, if we are seeking health care and health treatment, you know, we should definitely be treated and treated fairly. So thank you for giving us that awareness and for giving us those takeaways about what we can do, everybody on the call, to kind of help bring balance and make it more equitable for all people. Thank you again, Jason. You know, I always appreciate when you do this, when you facilitate these calls. You do such a wonderful job. I thank you guys. I really do appreciate the young people. I appreciate the energy you bring. I appreciate your perspective. And I appreciate that you are open and honest and just, you know, just tell it like it is. I really do appreciate that. And you do, in that respect,